Hello, I'm Dr. Voon maternal fetal medicine specialist from Sarawak General Hospital here in Malaysia, on the Bornean part of Malaysia. And thank you for this honor and privilege to literally walk you through what we normally do in our unit with regards to first trimester screening. I know the topic is on first trimester anatomical screening. I'm just going to show you how the work processes go around here. If you just follow me. So we have different forms available when patients step into our fetal medicine unit. So you have proformas for mid-trimester and for first trimester screening. When the patient comes in, they immediately are given this form if they're here for first trimester screening, and well, they are seated around and it's self-administered. So the patients, while waiting, they'll fill this form up, and if they do not understand, we have staff who are around here to help them. Their blood pressure is immediately taken by our staff and recorded twice on the left arm and twice on the right arm. And as you can see, the form also requires various other details when it comes to first trimester screening, including the height and the weight. But we are quite fortunate here in Malaysia. Because this is a copy of our national antenatal handheld antenatal records, and within the records there's already the height and the weight of the patient documented there by the clinics, and they are usually quite recent and within a couple of days of the scan. Once all that has been sorted out, the questionnaire, the proforma has been pre-filled. The proforma, I'm sure many of you are aware, will just ask certain details about the patient's demography, race, previous pregnancy outcomes, and complications. Whatever it is that we require to perform a first trimester aneuploidy and preeclampsia screening. And we proceed next with the scan, and once the scan is done, it gets imported into the system, and we can perform risk calculation here. But even if you do not have the software available to calculate the risk assessment, there are freewares available online. There are risk calculators online which you can use. So we will have a look at how we perform first trimester screening after this, but with a focus on first trimester anatomical screening or structural screening. Right, so today I'm going to show you how a first trimester screening is being performed. I think what's important, first of all, is to make sure that the setting is correct, that you're on a first trimester setting. All right. We have a patient with us here today who is about 12 weeks of pregnancy. Okay. And the other thing that we will go through at some point later is here on the right side of the screen, where you have the thermal index for soft tissue, thermal index for bone, and mechanical index. We'll talk about a little bit more about this when we move to the lecture on safety. So the first thing in terms of ultrasound in the first trimester, we frequently get asked, doctor, is it safe? My baby is still so small. So this is just to show you a chart with regards to the thermal index. It's something that we look at, and if you look at the picture on the top left corner, it says there TIS, TIB, that stands for thermal index for bone, and thermal index for soft tissue, and MI stands for the mechanical index. Essentially, in the first trimester, we mainly look at the thermal index for bone. As long as it's less than 0.5, that's all right, and mechanical index of less than 0.7. But ultimately, the aim is to observe ALARA, in other words, as low as reasonably possible. Right, so to start off, first of all, what we need to look at is the uterus as a whole. At this gestation, I think you need to identify your landmarks. That's the mother's bladder there. That's the cervix. And one of the first things is you want to make sure that the pregnancy is within the uterus. It's intrauterine. So you just need to follow the cervix, which is almost always behind the bladder, and go in here, and you can see the demarcation, the outline of the uterus here. That's the uterine wall, and some of the chorionic tissue, and the placenta. All right. And depends on the baby's position. If the baby's in a good position, you can go on straight to the nuchal. If not, then we can look around first for whatever the baby wants to show us. So basically, what's important as well is to narrow your window. Or when you do a scan, you want your angle to be as small as possible while keeping the focus on important structures that you want to go through. You will next use the depth button to zoom in on the area of interest. Now, I find it important at the beginning of the scan always to reassure the mother by showing them that the baby's heart is present there, right? And you can, of course, use the Doppler. And I find that for most women, it is quite reassuring for them to know that, you know, baby is alive, they can hear the heartbeats themselves. And you can do some measurements of the fetal heart rate just randomly, even over any waveform here, all right? So you can see that this machine requires 2 waveforms, and that gives you the heart rate of 159. Of course, you have to be careful. I'm just going to repeat this again. Now, in some machines, the waveform might have changed depending on the setting. So let's say if the machine tells you that you require 4 heart cycles, as indicated here on my finger on the console, then you will have to move it to 1, 2, 3, and 4 cycles, right? If you are going to measure incorrectly over 2 cycles, you might just get a fetal tachycardia. Right, so moving on, what's different in very early pregnancies is that, you know, in some babies, beyond 11 weeks, it's quite safe to use the pulse wave Doppler that I used earlier. But in some pregnancies, when you want it to be performed earlier, you want to avoid using pulse wave Doppler, and you might use the M mode. All right, and you can see here, you can just take 2 waves based on the setting here, and that automatically gives you the heart rate of 159. Now, we're just going to go through one by one, depending on what the baby is going to show us today. Okay, we just have a gross overview and look at the baby, and already you can see so many things which are normal and reassuring, right? You can see the fetal spine here, from the neck to the back to the lower back. And what's important is when you're doing a first trimester scan is to improve your visualization. And you can see even in the sacral region, that looks good, right? And at the same time, when you have an overview, you can already see important structures like the fetal stomach there. The heartbeat is relatively normal, it's not bradycardic. And because the baby is in the prone position, that's always very challenging when you're doing a nuchal, but we will take it as we go along. We have here the baby's skull. It's no different from you doing a BPD. What's important is to increase the depth and to have an appropriate magnification. Now, in some cases, in some guidelines, such as the eStroke guidelines, it is recommended that a BPD be measured, okay? And I think that's important because that forces you then to have a look at the fetal head and skull. And you can see here, we can exclude things like anencephaly with the skull completely formed. You can see the midline forks, and that excludes the most severe forms of hollow prosencephaly. You can also see the choric plexus here on both sides, what is otherwise known as the butterfly sign. So that's a good sign of normality. In cases of spina bifida, you may not see the butterfly so clearly. It will look as if the brain is quite dry, in other words.
Can you appreciate any intracranial abnormality in this patient? What's obvious, even in this early gestation, is the presence of a monoventricle and a fused thalamus, typically seen in hollow prosencephaly.
Not unlike in your second trimester screening, when the baby is in a prone position, in addition to the spine, what could be useful is for us to try and have a look at the kidneys as well. want to narrow down our angle to the area of interest using this button here. You want to increase your depth and you want to increase the magnification. So the kidneys are normally more echogenic in the first trimester because they have not started filtering the urine. I know it's a little bit unclear here, but if you bear with me, you can see one of the kidneys here on one side of the spine. That's how it looks like. It's a bit more difficult in the first trimester to demonstrate the presence of the kidneys using Doppler, unless you have more advanced settings such as low flow settings. You see here the renal arteries on both sides going in. Now we'll just go back to the brain a little bit because I'll just show you some variations of how they can look like. So that's your correct plexus. This is where you might see some cysts which occur later in the pregnancy, known as correct plexus cysts. You can see more clearly now the midline faults. And perhaps more clearly here, the aqueduct of Sylvius. It is a sign that we look for in the first trimester to exclude spina bifida because what has been described as a crash sign in babies with spina bifida, this aqueduct of Sylvius can be nearer towards the posterior part of the skull, as if a car is crashing into the back of the skull. Now we just turn slightly and now we can see both the baby's orbits here on both sides. And if you are careful, you can even examine the baby's lens here. In this view, you can actually see the fetal lens on one side of the eye. And you can see the other lens over here. We've missed before babies with having just one eye because they can see the orbit, which is slightly smaller, but you didn't look for the lens. So this is the retronasal triangle. And that's the primary palate going across. So if you can see this triangle, it's a good marker of the normality of the palate in the first trimester.
A little clearer in this image here, showing the different parts of the retronasal triangle, the nasal bone, the frontal process of the maxilla, and the primary palate.
Now, we just have to scan whatever baby shows us as we go along, and you can see here, baby's trying to give us a wave. That's the hand there. And in the first trimester, what's interesting is that, in some babies with aneuploidies, the hand tends to be in a fixed grasped position. But in the first trimester, it's quite easily seen that the hands are actually open. As you can see here, the hands are open like that. When you're imaging the upper limbs, you want to split your screen. Show that you've actually seen both hands. Yeah? And sometimes you can already see that both the radius and the ulna are there. And it's really important to see the thumb here on both sides of the hand.
In comparison, upper limb abnormalities are not difficult to spot in the first trimester if you're looking for it. See how the wrist of the fetus is markedly angulated here, in this fetus with radial aplasia. In the second image, you can appreciate the normal left hand compared to the attitude of the abnormal right hand.
I'm going to zoom in. I'm going to split the screen, show the stomach there, and at the same time slide slightly towards the thorax, where you can see the baby's heart. You can appreciate the interventricular septum there, and you can appreciate that the spine posteriorly going upwards here, and that's the fetal cardiac axis going across. So you can see that the axis is correct, the spine is on one side, the heart is facing towards the left. And you want to, of course, make sure that the left ventricle is on the left side and the right ventricle is on the right side. It's not very apparent here, but if you bear with me, you can see that this whitish area here, that's the moderator band. And you can see that the apex is slightly more clear down here. Right? So that moderator band tells you that it's the right ventricle, and this is the left ventricle, simply because in the left ventricle, you can see that it stretches more apically here. I'll just outline that for you, compared to the right side. Where you have the moderator band here. So the other thing with the fetal heart is you need to make sure that you're on the right setting. I find it very helpful to have a first trimester cardiac setting. I'll just change that to sepia. We'll focus now on using Doppler. I cannot emphasize how important it is to use Doppler in first trimester screening of the heart. Now this is an image of the baby's heart. You can see here the interventricular septum. You can see both the outflow tracts. It's mainly because of the angle that this appears smaller, but it's actually quite normal. And you'll also be able to appreciate the crossover. And from the 4-chamber view, if you sweep slightly upwards on the baby, you will get a V sign here, which represents the outflow tracts of the heart. It's important to appreciate that both sides of the heart are relatively the same size in terms of the outflow tract. I'd just like to show you something here. You can see that both hands are meeting in the midline. Okay, so that's an important sign. For some babies with dysplasia, you will not expect both the hands to be able to cross the midline to meet each other because the bones are just so short. So this, in fact, is an important view and a clue to exclude some forms of lethal skeletal dysplasia even early in the first trimester. Although it's not routine, but it's an important sign of normality to see that both hands are able to cross each other. Now we have a look. The baby's bladder isn't very apparent here at the moment. You can see the baby's spine. Yeah, but we've gone through that earlier. The baby's bladder is not so apparent. You can see as well the genital tubercle here. This isn't a baby boy, but that's the genital tubercle, and if you really want to assess for gender, you will have to measure this angle. It's only if the patient wants to, so we'll not do that at the moment. And you can see the lower limbs here. That's the baby's foot on one side. And that's the baby's foot on the other side. I try not to diagnose talipes in the first trimester because they are frequently inaccurate. So although this foot might look like it's at the wrong angle, but you have to turn it properly to have a look. So that looks like a good angle between the feet. So another view of the cord insertion that's slightly better now. You can see how it enters the abdomen. Here, coming over here. So I think Doppler is very important in the first trimester. You're going to assess for all these structures. You can see how it moves here, coils over here, and shows that it has two branches to it. And normally you'd be able to see the bladder here. You almost always should see the bladder in the first trimester.
It is important to look at the cord insertion as you may detect lesions like these. Any idea which one is abnormal? The upper left image shows a physiological bowel herniation, while the upper right image is a fetus with an omphalocele. Lethal conditions like pathology of Cantrell can also be detected. Umbilical cord cysts are seen here in this fetus.
Our baby's really cooperating with us right now. It's in a relatively good position. So I've shown you that it's possible, in most cases, to look at this tiny baby in the first trimester to do what is equivalent almost of a detailed scan in the second trimester. But there are limitations, and we will talk about the limitations of a first trimester screening for structural anomalies in a short while. So this baby is merely 6 centimeters, and yet we can see so many things today. A few other things I'd just like to show you. When you want to measure your nuchal, you have to include just the head and the upper thorax. You want to make sure that the baby is in neutral position. You want to make sure your focus point is in the right position and bring it down. You want to make sure that the gain is correct. You can see the nasal bone clearly here. You can also see the IT here, another indirect sign of spina bifida. And although the baby is slightly more flexed than I like, you can see the nuchal perfectly here. Now you'd like to measure an area that's the widest, so you're not measuring here. Instead, you will try to measure over here. And the caliper has to be on and on. Granted, it's not the best position because the baby is a little bit too flexed, but I think that is not the purpose of the scan today. We're trying to look for anatomy. In smaller babies, the structures might not be so clear, but they tend to sit more quietly.
You can see cystic structures around the fetal neck. And here, more typical appearances of cystic hygroma resembling an astronaut sign in the image on your left.
So one more thing before we finish off is to have a look at the uterine arteries. So the first thing is to quickly look at the cervix, where the internal os is, and you would expect the uterine arteries to be here and on the other side. So you're going to turn on your Doppler there and sweep just gently from side to side. Usually it's the first vessel that turns up. So there are a few ways. You really want to make sure a few things, that your gate is in the correct 2mm angle. This gate here, as you can see over here, the gate size is 2mm, and you want to make sure that you're parallel to the vessel, so you have to adjust your angle slightly. Okay, so that's important because when you adjust your angle, you will affect the overall scale here, alright? And sometimes you can see that the waveform is too high, you want to bring it down with the baseline. That gives you a better measurement. And you can see here our uterine artery PI. Just going to do that again. You can see here the PI is 1.6, which is quite normal at this gestation. So if you have difficulty in locating the right uterine as I have, the other way is to make sure that you're not moving too fast, because you know where it is. You know that this is your internal os, alright? And you just have to sweep slowly from side to side. Let's try that again. So you have difficulty like what I'm encountering now. The other way is to look at the transverse technique. So now I've put the cervix down here, and you expect the uterine to appear on each side there. Okay, so you just have to sweep downwards, and immediately you can visualize the uterine on the left, on the right side, which we couldn't identify earlier. And just keep your eye on it as you go along. And that's where you'll be measuring it. Now you just want to make sure that when you're measuring, the gate size is correct and the angle follows the vessel direction. Because when you adjust your angle, as you can see here, the scale will change, alright, as you adjust the angle. Your angle should not exceed more than 20 degrees. Going to keep it there. If you can see what I'm talking about, as your angle changes, that changes the peak systolic velocity. So it's very important that you're scanning at the right angle, following the vessel where possible. And you can change your gate. I'm just going to show you here. That's your gate. So different machines has different functions, but you can change your gate size. But because the uterine artery is a small vessel, it's recommended that the gate is at about 2 mm.
Why is first trimester screening for structural anomalies important? Because you don't want to diagnose lesions like this in the mid-trimester. This is an ectopia cordis shown here. Or even worse, only diagnosed after delivery. A little bit of training and confidence makes a whole lot of difference. Now this case was referred to me from a district hospital 800 kilometers away, so they shot a video and asked my opinion. Our junior specialists were able to screen and detect this multiple pregnancy where one twin appeared normal while the other twin's fetal cardiac activity could not be seen at all. Eventually we saw and diagnosed this as a twin reverse arterial perfusion. But the reality is that not all images in the first trimester will be crystal clear. What the textbook images show you may differ from what you actually see, especially if you're screening mainly from a transabdominal ultrasound like in my unit. It is important as well to know your limitations, what can be detectable, what is usually not detectable from ultrasound in the first trimester, and those in the gray area in between. With this, I would like to end my presentation by showing you a short clip of a beautiful state in the island of Borneo I call home, Sarawak.